We're recording now, I hope. Okay, we're recording now. So as I said, I apologize. I did not hit the record button, so I'm going to go through some of this again. Nothing like starting over. I basically want you to understand what a trach is, how it works. I want you to understand what questions to ask, and I want you to know the pros and cons. So as I said a few minutes ago, before I realized I hadn't pressed record, there's not a right or wrong decision. It's an individual one. Really, education, 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 so you understand what may happen in the future, so you make that right decision. Discuss with your medical team, with your family members, with caregivers, but the decision is basically up to the person with ALS. And as I said before, we want to talk about it now. We don't want to wait till an emergency situation. And once again, I apologize for not hitting that record button. So non-invasive ventilation, as I said, is ventilation that does not have a surgical incision. So these are some face masks. It's all things that are going to be a mask, some kind of facial interface. This is the full face. The one in the middle is a nasal pillow. The one on the end is a facial interface. Invasive is that incision, a surgical incision, where a trach tube is inserted into the trachea, and there's a picture of that. Okay, here we go, guys. So what is a trach? As I said before, I hope you can see my pointer. This is a trach right here, and this part, this face plate, is what sits on the outside, and it's attached with a trach tie that goes around the neck. This piece here that's labeled outer cannula, that is actually, and the shaft, that's actually the trach itself. We call that an outer cannula because here at the bottom, you can see an inner cannula. Well, why do you need both? The inner cannula is something you can remove in and out for cleaning purposes. If you have a lot of secretions, you can remove the inner cannula, put in a new inner cannula. It helps make sure that that airway is kept open and clean. So you switch in and out the inner cannulas as often as is needed. I will point out this cuff, that's deflated. This pilot balloon blows up that cuff. It's like a little balloon. It helps stabilize the trach in the airways and helps keep things from falling down in that sit on top of the cuff into the airway. But if you do, for some reason, deflate the cuff, you need to make sure you suction really good before. Okay, let's go. So why would you even consider this? What are some of the reasons that a person might consider getting a trach and invasive ventilation? A couple different reasons. Maybe the BiPAP or whatever the trilogy, whatever term they're using, your non-invasive ventilation is no longer working up to par. It's no longer providing the full support that you need. You need that little extra something. It's unable to relieve the respiratory issues that you're having. It's just not doing it. So that's one reason. Another reason sometimes people get a trach is if they're having a lot of trouble with secretion management, really a lot of saliva, not being able to manage it, not being able through medicine or something like that to really get a good control over it. There, with that, you worry about an increase of aspiration pneumonia, which is when things get into the lungs causing pneumonia, an increased risk of mucus plugging because of those airway secretions, and a risk of just aspiration of pooled saliva when you're using non-invasive ventilation. They call it a contraindication to non-invasive ventilation, or a reason why you wouldn't want to use non-invasive ventilation. Let me break that down. Think about it. You got a lot of pooled saliva in your mouth, in the back of your throat, and you're providing your respiratory support with a face mask on your face. That's blowing into those pooled secretions, which will blow them down. Whereas a trach is going to be below those secretions. Okay. Hopefully that'll explain it. I need to use this button. So what are some of the advantages? Let's talk about the good part of this whole thing. It will provide a longer survival period. Bottom line is respiratory failure is the main reason of someone passing away with ALS. Okay. Those muscles in the diaphragm, the muscles of breathing around the ribs just aren't able to bring in enough breath, respiratory failure. So what happens is with this trach, that takes that out of the way. It stops that because the machine's breathing for you. It's doing it. So it will control your oxygen levels. It will make sure you get a big enough breath to blow away that CO2 waste gas. It controls that stuff. It also rests your respiratory muscles. What I mean when I say decreasing the work of breathing helps with energy conservation, what I mean by that is the machine, instead of using those muscles to try to really get that breath in, working really hard, once you start that breath, the machine comes up behind you and goes, let me help you. Here's the breath. So it takes away that really work that those muscles are doing, saving that valuable energy. Also helps with shortness of breath. Two different things, meaning it gives you that big enough breath to be able to exhale that CO2. It can prevent aspiration, and it can be provided without mask. Obviously, it attaches right there. It's a real secure attachment. You don't have to worry about leaking from the side of the mask, or you don't have to worry about the pressure being so high on the mask that it has to be real tight because otherwise you get leaks. Okay. So sometimes that just causes an irritation of the mask, takes all that away. And using non-invasive ventilation or that positive pressure, that air coming in, sometimes it has its own problems. Some people, because think about it, the air's all being blown in through the nasal passages and through the mouth. It can cause irritation of the sinuses. It can cause stomach bloating. Okay, I've had a lot of people say, it's really bloating their stomach. And as I said before, if your saliva is not managed, it can be dangerous. So those are, let's go toward the using a trach. That takes away those things right there. So those are some of the advantages. Well, anytime you talk about advantages, excuse me. Thank you. Anytime you talk about advantages, we also need to talk about some of the disadvantages. So what are the disadvantages? I just told you that it helps with secretions. Now I'm going to turn around and tell you it increases secretions. So you're probably thinking, good grief, what in the world am I talking about? Anytime you add something, especially into the airway that's foreign, the trach can really sort of interfere with your body's normal ability to clear the airway. So it causes more secretions sometimes, causes more need of suctioning sometimes. And anytime you have more secretions, we worry about mucus plugging. But remember, you can take out that inner cannula and clean it. Anytime you add another opening into the body that's not there, and when I say stoma site, that's the site, the opening in the neck, the stoma. So, and it's not normally there. Anytime you add a new opening, then you get an increased risk of infections. Respiratory infections also, can increase at times. There's also safety issues. What happens if the ventilator malfunctions? What happens if there's a disconnect or a decannulation? What that means, disconnect, the tubing comes off. Decannulation, the whole trach comes out. Doesn't happen very often, but you are trained in how to fix these, how to deal with these things that happen right there. But it is something, I guess you could consider it a disadvantage. One of the biggest things I think, you guys, is that you have to have 24-hour care, okay? No ifs, ands, or buts about it. Do I mean you have to have someone sitting right next to you all the time, staring at you? No, but you have to have some systems set up in your house, not just the ventilator alarm, okay? A call bell, something, a baby monitor, something set up in your home where you are able to connect with your caregiver. What if you need suctioning? Okay. What if you need some help? So that's what I mean by 24-hour care. I will tell you that there's a high turnover right now of in-home skilled nursing staff. I just think the home care industry is really, the home care skilled nursing industry is really struggling right now. There's also sometimes it's not, the care isn't fully covered by insurance. I don't go into insurance coverage because everybody's policy is different. If you have Medicaid, if you have Medicare, it's all different. I suggest that you reach out to your insurance care company and find out what they will and will not cover. And also, if you don't have this extra care, it's a lot put on the caregiver, and we do see an increase in caregiver burnout. Financial resources, it can be quite costly. And if you're considering going into a facility, not all facilities take ventilator patients. So that's something to consider and something to look at. Okay. So let me hop up on my soapbox real quick, because I hear this, I've heard this several times. Well, I'm going to get a trach and then basically everything's going to slow down. I cannot stress to you enough. No, it will not. Okay. What you're doing with that trach, you're stopping respiratory issues. Okay. You're providing respiratory support. Pretty important. Yeah, yeah. But it will not stop the disease for progressing. Okay. If you're able to walk, the disease is going to progress. So I want to make sure that people realize the trach itself takes care of the respiratory issue, takes care of that, but it will not stop the disease from progressing. So there's like people who do really well, and there's some people who do fantastic, you guys, with a trach. So they tend to have certain characteristics. They're really highly motivated. They want to still go out. They want to still be engaged with folks. Okay. They understand all these things that they're talking about, and they've educated themselves. They're willing to take extra steps to communicate. They're willing to work with the eye gaze system and use an eye gaze system. They're okay with that. They have a lot of support, whether it be family, whether it be friends, whether it be a multidisciplinary clinic. And in some instances, they have the resources to be able to carry on with caregiving, things like that. So, does getting a trach mean use of a full-time ventilator? I added this next part because of some stuff that have happened recently. So right after you get this trach, what they do is they're going to either keep you in the hospital for a little bit, and I'm going to talk about this in a second, a little bit more, keep you in a hospital, or they're going to take you to a rehab, sort of do training to get you to that next step to either go home or a facility, wherever you decide you want to go. Okay. And I'm picking on my own profession. Okay. Respiratory therapists can pick on respiratory therapists, because what I've seen happen is they get you in these facilities, and it is a respiratory therapist goal to wean you. Let's get you off the vent. Let's get you off the vent. That is the norm. But what we need to remember is with ALS, it really shouldn't be the norm, because one, what have I just said a second ago? This disease continues to progress. Those muscles of breathing, and this is a great picture, the diaphragm's that big red muscle under the bottom, but all these muscles around the ribs, between the ribs, are all muscles of breathing that are affected, and they will get weaker over time. And this will mean that you're not getting that big enough breath in, you're not able to blow out that CO2. And what worries me is when they start doing weaning trials in facilities that they look at the oxygen level. Your oxygen's good. You're doing great. Your oxygen's good. You cannot use oxygen levels to determine the success of weaning of an ALS patient. Unfortunately, the level that they should look at is the CO2 level, and it is not as easy to obtain as an oxygen level where they put that little thing on your finger. They either have to take an arterial blood gas, or some facilities have what we call end-tidal CO2 monitors. Not very many have. So they look at oxygen. They look at oxygen. So what I would say is, while going off the ventilator for small amounts of time might seem to work in the beginning, might be doing good, continued weaning, use of a trach collar. What that is they take you off the vent. They put like this collar sort of cover over that has humidity to it. It can lead to problems if you're not properly monitoring it. So let me give you an example, and the reason why I added this in this time. I was speaking to someone recently, and they said they're weaning, their friend. I said, well, let me ask you, what are they using as a determination? Because they were going 6 hours and then they drop back. Then they'd go 8 hours and then they drop, the next time 4 hours. So, well, what are they using as this determination to wean? And she said, well, they stop when the person gets really tired and their oxygen levels dip. I'm telling you, as a respiratory therapist, that one, that infuriates the mess out of me. Two, it's a misunderstanding of how this should be done. And three, that patient should have been put back on the ventilator long before their oxygen levels went down and long before they weaken themselves out from breathing, okay? But it's a mindset of respiratory therapists in a rehab facility, okay? So we've got to remember that in these situations. What happens when this shallow breathing happens is a person retains their CO2, which is very dangerous. It's your waste gas that we get rid of. You retain it, we got problems. It's going to increase your work of breath, working those muscles, increase that shortness of breath, not get the big enough breath. All of that leads to respiratory distress. We don't answer respiratory distress, we end up with respiratory failure. So I got a trach. Now what? Okay, I'm going home soon. Yep. So after the surgery, what they're going to do is they're going to put you in rehab, as I said, either in a hospital or a transitional rehab. They're going to start training for caregivers prior to when you get home. And even if you're in a hospital to a transitional rehab, they might start training in the hospital. Wonderful. Love that. Absolutely love that. So you're going to start training with I'm going to call the rehab, I'm going to call them hospital staff. You're going to be training on that side, and then you're going to get a durable medical equipment, DME, company that has a respiratory therapist involved in it. They're going to provide you the actual machine, the actual ventilator, the suction machines, all the things that come with it. That's what they provide. A good respiratory DME company should come out to your home. They should look at how many electrical outlets you have. Older homes, I remember when I was working in Norfolk, some of the older homes would have one outlet in the wall. You cannot plug all these machines into one outlet on an extension. Oh, good grief, I can't think of the word of it, but the extra plugs where you plug one in, can't think of the word of it. Can't use those. You have to have plugs in the wall. So they should come out and do a home safety electrical evaluation. They should look to make sure that you can get in and out of the house. They should, a good company will do that. Now, things are changing over time with insurance. So, I'm not sure how many do that, but if not, you should look at your home safety evaluation. Prior to discharge home, caregivers in most cases And if you're not required to, I would request to do what I call a room in. In other words, they're going to bring into the hospital or the rehab the ventilator that you're going to take home, your home vent. Then they're going to have the caregiver spend the night. I've seen it done 12 hours. I've seen it done 24 hours. That person has to stay there and do all the care. What's nice about it is if something happens, they got the backup of the hospital, but it does two things. It shows them they're ready to go, if they're ready to go, and shows everybody that, hey, everyone's trained, or we need more training in this. I think it's a great idea. If they don't tell you you have to do it, I would definitely request it. So let's talk about who can be your caregivers. Well, really, anybody can be a caregiver. It can be friends, it can be family members. So why do I said 24 hours, why do you need this 24-hour care? Well, obviously for emergencies, but what if you need suctioning? What about just the basic care of someone with ALS? You need that 24-hour care with a ventilator and a trach. Caregivers, they can be friends, they can be family members, they can be any responsible party. But I'm going to tell you something. Not caring for someone, if you have a family member, sometimes caring for someone with a trach-in event isn't for everybody, and that's okay. It's okay for a caregiver to say, I really love you, but I'm not sure if I can do this. Let's get somebody else to do it. Okay. We want to make sure that the person we have doing the care is ready and able. Now, you can get home health agencies. It has to be skilled nursing vent trained folks. It cannot be a CNA. It has to be either a LPN, licensed practical nurse, or a registered nurse with vent training. Okay. And sometimes not sometimes, all the time, that's really costly. The price of a skilled nurse for this care can be costly, and it's not always covered by insurance. So let's talk about who trains. You've got family members. They're not medical people. Who's going to train these willing people? Who's going to train them? So what I want you to think, I want you to divide it into two. Hands-on care, meaning trach care, changing the trach tie, cleaning the inner cannula, changing the gauze, cleaning around it, suctioning, emergency care, hands-on care. That's done by a respiratory therapist in the hospital or the rehab, okay? Make sure that they are training you. Make sure that they're teaching you how to suction. The respiratory durable medical company, think home equipment. They're going to teach you what the alarms mean, how to react to the alarms, what your settings are, how to clean things, how to order supplies. Now, a respiratory therapist that works for a DME company, they know the same stuff as hospital, but it's the way the license of the businesses are that say a DME respiratory company is not supposed to train on hands-on. Okay. When I did home care and I was training, I would distract the family and make the alarm go off on the vent. We had what we call a test lung. So the vent was going, and say, oh, the alarm's going off. Well, what is it? So they should be able to train you to where you're comfortable to react to all these things. The average stay is about 2 to 3 weeks. But a durable medical equipment company can hold that up. If something's wrong, you need a lot of work at the house, or the caregiver just isn't there, isn't cutting it. Okay. Excuse me. Let's talk a little bit about care. Does a trach hurt? After the initial surgery, there's really no discomfort. There really isn't. It heals really fast. Our body's amazing how they heal. They heal really fast. If you, however, have discomfort, it could be a couple different things. If it's discomfort around the stoma, the area where the trach is inserted, it could be that there's some infection, okay? Or it could be irritation. Maybe the ventilator tubing is pulling, which is making that trach tube sort of slide back and forth in the airway or at the top with the opening. There are things you can get to stabilize or hold the trach tube so it's not, pulling down, and stabilize it some. But overall, there's really no discomfort. Okay. So, hey, someone said I got to change this thing. I don't know why. I got it in here. I don't know why. Well, I can tell you why. You want to make sure that you keep the airway open, that it's a clean area, and you minimize the chance of infection. So I can't tell you, oh, it's going to be done every 3 months. It's going to be done every 6 months. Each individual situation may be a little bit different. Once the first trach change is usually, I tell you, never say never, never say always, but usually, I will say usually, is done the first time by a physician, either in his office or in the hospital, some area other than home, usually in case there is an issue. After that, it can be done at home by caregivers, and it's a very swift process. You get everything laid out, you get everything in a sanitized area, you take the trach out, you put the trach back in. Almost that fast, you guys, very swift. As I said, the frequency depends on situations. There's a thing called granulation of tissue, and what that is it's an overgrowth, and sometimes you see it around the edges of the trach. And if you have that, most likely you will have a trach change more frequently. It's needed more often because you don't want that tissue to adhere, okay? And anytime that cuff is damaged, you got to do a change. Changes, let's put it this way, normal average changes don't really hurt, okay? They're in, they're out. What does a normal day look like? Well, I'm not sure if there's anything such a normal day for anybody, but a normal day will include cleaning around the trach. If you have a lot of, and these are all things, can I tell you, oh, you do it twice. Oh, you do it 3 times. No, depends on the person, depends on the day. It can change day by day. So cleaning around the trach, if you have a lot of drainage, you might need more gauze, more suctioning, or more changing of dressing or gauze. It's very important that the gauze, you will get what's called split gauze. And you look at it and you think, well, I'm out of that split gauze, but I have some gauze over here. I'm just going to cut it. Please do never, ever, ever do that, because you might not notice, but little splinters of the material, if it gets in the airway, can cause a lot of trouble. Now, the inner cannula, which I showed you earlier, you need to clean it at least once a day. But if you're having a lot of secretions, if you have a cold, if it's a bad day, you may need to clean that inner cannula several times a day. Trach ties change usually every couple of days. Or if you have a lot of secretions in the mouth, you're going to be using oral suctioning. If you have a lot of secretions in the airway, you're going to do internal tracheal suction. If you can't cough that out, you're going to be suctioning. And that, once again, can vary day by day. Let's talk a little bit about the equipment that you're going to have. So there's various manufacturers of ventilators. Before, probably a couple months ago, maybe 6 months ago or so, I would have said most of you are going to have this first ventilator right there. That's called a Trilogy. It's by Respironics, Philips Respironics. In fact, some of you may have it right now. There was a slight recall on this machine, and down the road, Philips Respironics is getting out of that kind of business. whole nother PowerPoint. I'm just gonna say you might see this ventilator, probably gonna see it a little bit less as we go. All of these things across the top are ventilators. This next one is a ResMed Astral. Probably not gonna see this third one very often, but I included it because I found a picture. But you may see it, it's an LTV. We used that a lot, years ago. Used it a lot for kids, when I was doing home care. And this guy here, to be honest with you, never seen it other than this picture, and I think it's called a Breeze, don't quote me on that. A humidifier works in line with the ventilator because our nose, when we breathe through our nose, it humidifies the air that we breathe. We're bypassing that, so we have to provide some form of humidity. So we do that with these inline humidifiers. Here's a picture of it up at the top. There's another one right there, and here's just the humidifier itself. There are a couple different kinds of suction machines. You're going to use a suction machine for your internal suctioning of the trach, the airway, and of the oral cavity. This first guy looks so old, but I guess it's a case of don't need to fix something that works. It's one that plugs into the wall. It's a lot stronger than this next picture of the three. Those are portable. If you travel a lot, you may want to talk to your doctor about getting a portable. It's not as strong as the one that goes in the wall, but usually it should do, unless you have super thick secretions, and then we got to deal with that. That's another issue. But the portable trach, the portable suction, I'm sorry, good grief, the portable suction should work. It has batteries. You can keep it, it can plug into your car. But normally insurance will only pay for one. So you need to talk to your doctor, because if they send a script for a suction machine, I guarantee you, you're going to get the, this one here. And if you're home all the time, that's the one I'd go with. But if you travel and go out a lot and have issues with secretions where you need to be suctioned, then you definitely need a portable. So airway clearance devices. This, I'm only going to say this word once, hopefully. Mechanical insufflator exsufflator. That is the technical term for a cough assist. Cough assist was a brand, sort of like saying Coke and Pepsi. It was made by Philips. They are no longer going to be putting them out and servicing them, but there are other brands out there. This first picture right here is of a Baxter Hill ROM. It's called a Sinclaira. It is a, I'm gonna say it one more time, insufflator exsufflator, fancy name for cough assist. What that does, blows in a big breath, sucks it back out, which brings the cough up. It mimics a cough. The next two things on, well, the next three things on the bottom are what we call high frequency chest wall oscillation. What they do is they move airways up, they move secretions up out of small airways into larger airways so it can be coughed up or used a cough assist to get it out. As a respiratory therapist, I'm telling you, that's my 1-2 punch. I wish everybody could have that 1-2 punch. Somebody in the insurance company does not listen to me, so they will provide one. If you can only get one, get the cough assist, or, you know, whatever, the insufflator, exsufflator, get the cough assist, because it's not going to do you any good to work the mucus, the secretions up if you can't cough it out. Okay. So that's the bottom three, and that's a punch. My favorite 1-2 punch, but you know, it unfortunately. The next one is something that we haven't seen a whole lot of out in the field, but I think we're going to maybe be seeing it a little bit more. It is not, and insurance drives this a lot too. Once again, they're only going to pay for one in most cases, and it's going to need to be a cough assist. But this guy down at the bottom is also a Baxter Hill ROM product. It's called a Valera. Where they get these names, who knows? But it is an oscillation, so it moves those secretions, and it also provides lung expansion, which is really nice because we're not able to do it on our own. So your durable medical respiratory therapist is going to teach you how to use these things, how to clean them, how to order supplies. Okay. Excuse me, I got a dry throat today. The thought of an emergency can be very frightening. So let's talk about it. What happens if your ventilator breaks or it malfunctions? Some insurance companies will provide a backup ventilator, but insurance, sometimes they won't. So try to figure out if you can get that backup ventilator, but if you don't, we still have to have a backup. So we're going to want you to have a manual resuscitator bag. That's a fancy name for an ambu bag. So most of us call it an ambu bag, and here's a picture of it. It provides, you squeeze that blue part, it provides breathing when a person can't on their own. You're also going to want to have extra supplies. If it's the tubing, if it's the filter, have those things readily available. Have the number of your DME readily available. They have 24-hour on call. And there's also, in big instances, 911, obviously. Now, take the ambu bag from the hospital room, you guys, because they're going to throw it away. They throw away everything, and most likely you've been charged for it. But more important than that, make that, or ask, not make, that's not a very nice way to say it. Ask that respiratory therapist in the hospital or the rehab place, show me how to attach this. Because right now you see that's attached to a mask. If you've got a trach, you don't want to breathe through your mouth. You want to attach it, and it can attach right there at that point to the actual trach. So be trained, know you need to be trained, get the education. So what happens if you don't have a generator and the power goes out? Anytime you plug these ventilators into an outlet, it's always charging. It's always charging. So I tell people, leave it plugged in. When you go out to dinner, when you go to a friend's house, when you go to the airport, go to a plug, plug. Okay. Now, some companies will give you extra batteries and chargers. I see that less and less and less. Never hurts to ask, but don't be surprised if they say no. Okay. So what do? These ventilators have internal batteries. They've got, well, they actually have two batteries. They have the battery that you can charge. Okay. And they have an internal battery. If they tell you this ventilator has an 8-hour battery, they're talking about that outside external battery. But I'm going to tell you that's a fully new battery, fully new ventilator. When anybody told me 8 hours, I always said 6. And I'll be honest with you why. Because they're basing that 8 hours on basic settings. If your settings require more energy, your battery's going to go a little bit faster. Okay. So I always never go by the full amount. I always sort of go a little bit lower. Okay. Let's see. You want to keep them charged. Oh, that internal battery, I said, you know how it has two batteries? You don't want to rely on that internal battery. If that external battery goes dead, it will revert to your internal battery, but don't really consider that as a backup, because once that internal battery goes, you're going to have a hard time charging the whole thing. Consider it as truly an emergency battery. So what if my trach comes out? Doesn't happen very often, but never say never. As I said, keep an extra trach within reach. Let me tell you, they actually, normally what they do is they give you a trach that's one size smaller, that if by some chance the trach came out, the smaller one's easier to get back in if the tissue may be swollen from the trach being pulled out. And I've had people put them right where they can reach. I've had people tape them to the walls. What you don't want to do is put it down the hall in the closet in that blue box that's on the third shelf. Don't do that. Have it in reach where you can get to it fast. And I'm a big fan of keeping a to-go bag with basic supplies because you can go, okay? So I added these next two slides because these are asked questions that people have asked me in the past. Can I talk with a trach? And I'm going to tell you, it's not really a yes or no and yes or no answer, because I think I might have said it before. The disease will continue to go on. If a person's able to speak prior to getting a trach, they may be a candidate for a speaking valve. This thing right here that you see is a speaking valve. You may hear it termed Passimir valve. That's a brand name. Here's these pictures on the side are the speaking valve in line with the vent. Picture in the middle is actually a person with the speaking valve on the trach. I am going to tell you, I have to be honest with you all. I'm not a real big fan of a speaking valve with someone for ALS. And here's the reason why. Here's how it works. Well, first of all, if you're in very progressed in your progression of the disease, or if you're bulbar onset, or if you have a lot of secretions, you're not going to be a candidate. And here's what happens. If you look at this middle picture, it's a one-way valve. Technically, it's a one-way valve that when you breathe out, when you exhale, instead of the air going through the trach, it is pushed up across the vocal cords. So let's think about that. You have to have enough strength to get a big enough breath to be able to project up and over. It takes a lot of strength to use a Passimir, a speaking valve. So to be honest with you, I'm not that big of a fan of them, but I'm not going to say, you can't never use one, but I'm not. And I will tell you also, if you go to the Passimir site and they have all these classes you can take, and take the class about putting a something in line with a ventilator, because this person in the middle, they're not obviously using a vent, but if you need a vent, you put it in what they call in line. But to do that class that they had basically said, you may need to change the settings on your ventilator because you have now added a leak to the system. So you have to include either more pressure to overcome the leak or more volume to overcome the leak. And I'm going to tell you, I don't think you're going to find a respiratory therapist company that's going to let you manipulate settings on a ventilator. And what happens if you adjust the settings, but forget to return back to normal after you take the ventilator? That could be very dangerous. So same thing about, can I speak? Had people ask, can I eat? Well, it's the same answer. It depends. So ALS, as you know, affects the muscle tone, the throat, the mouth. It makes eating difficult, makes moving the food, makes swallowing difficult. And so what happens is a lot of times they'll do surgery for a feeding tube at the same time as trach. Now, if you are aspirating or having problems before eating with the trach, it's not going to happen. It's not safe. It's extremely dangerous. Also, let me tell you, just the way the body is, even those without ALS, those that have a trach for some whatever reason, swallowing can be inhibited and hard to do, the mechanism of swallowing, because of that trach tube in there. Okay. So if you, most of the time they're going to say no. In early stages, you may try pleasure foods and stuff like that. But as I said, having that cuff and that trach in there sometimes make it more difficult. And excuse me, end stage bulbar, decreased muscle tone. Nope, not at all. And I wanted to jump back and say, a lot of times, they talk about breathing numbers. We're talking about breathing, and suddenly we go off on that feeding tube tangent. What the heck are we doing? The reason we do that is we track your breathing numbers, And these low numbers mean that you're having weakness in those respiratory muscles. And that weakness causes that shallow breath and affects our whole, what respiratory therapists call respiratory drive, fancy word for the way we breathe. So if you have real low breathing numbers, you're not breathing strong, really weak muscles, really shallow breaths, and then they put you under anesthesia and sedate you and put a tube down your throat to breathe for you while you're in surgery, there is the chance that you're not going to be able to breathe on your own after being intubated, after being not intubated, after the tube's removed. I need to fix that. And sedated after your sedation. So what happens if I cough? This is sort of my what ifs. What happens when I cough? Do I need to worry about that trach coming out? No, you don't. It's held in place with a trach tie. It's not right up against you, but it's not going anywhere, y'all. And sometimes the secretions might come around, so you might just need to, suction around and then suction the mouth. If you can't cough, you can attach the machine straight to the trach, okay? So you have that ability to still get rid of those secretion that way. Now, this is a whole PowerPoint, you guys, and I'm gonna do it in about a minute, but I'm gonna get up on my soapbox when I do it. So oxygen really makes me feel better. I'm just gonna use oxygen. Every respiratory therapist who understands ALS, and probably every care service person out there, cringes when they hear that. ALS affects the diaphragm and the muscles, as you know. These muscles, they're providing, when I say ventilation, they're providing the muscles to draw the air in and out. As that weakens, you're not able to provide in and out. So ALS is really a ventilation. It's not an oxygen issue. And what happens is, why people say, well, I felt great. I felt great with that oxygen. I'm just going to use that oxygen. It's the sense of flow. It's that feeling of flow coming in. Okay. It almost makes it feel like you're getting that breath. You're not, you are not, you are not, you are not. So providing supplemental oxygen without some form of mechanical support can cause or accelerate respiratory distress. In bold, because I'm going to read it again, providing supplemental oxygen without some form of mechanical support can cause or accelerate respiratory distress. I'm not going to get into the science behind it and what your brain thinks when it's happening. I'm just saying, please don't do it. Please don't do it. If you're using supplemental oxygen, have them show you how to, what we call, bleed it into your machine. Now, am I going to tell you, if you had good lungs, didn't have anything wrong with your lungs when you got this diagnosis, you got good lungs with it. Lung tissue, got good lung tissue. But some people had pre-existing conditions, COPD, etc. They may need oxygen bled in with their ventilation. Saturation levels go down at the end. They may need it being bled into their equipment. But most ALS patients don't need oxygen at all. Let me step down off my soapbox for a second. But what about a shower? Well, you never at any point, and these are all questions that I've been asked, so I'm gonna share. What about, you never want at any point the shower head to be coming at you or anywhere near your trach, because you do not want anything to get in that. But I have had people use this trach bib. I have had people use this shower basin, and I've had people use sponge baths. But whatever you do not want any water to be able to run down into that trach area. So what about my pets? And my dog's sitting right here beside me, luckily, quiet, which is unusual, but I believe pets are a big part of making us feel good and are a big part of our family. And we want them around. So if you have a pet that sheds a lot, you may need to vacuum more. You may need to brush more. but they're still allowed to be around. Keep supplies and tubing out of reach. You know, cats. Here comes that cat with that tubing. And keep pets away from the trach side. I had someone who had a bird that would have it sit up here, and I'm like, hey, could you have it sit over here? And this has nothing to do with pets, but it has to do with the walls in your house, I guess you could say. If you put a ventilator on the back, sometimes they have a tray on the back of the power wheelchair. Remember that when you're cutting those corners, because I've seen people slam the ventilators into the wall. So we're heading almost down, guys. What kind of things can I do to stay healthier? Oral care. Your speech person's going to tell you your mouth is a dirty place. So you should brush your teeth if you can, to get rid of the bacteria. Toothaches, mouth swabs can be attached to suction machines. They literally hook on. Dental visits. Now, I'm going to be honest with you. That one's a little bit harder because a lot of dental, if you're in a power wheelchair, it's hard to find dentists that will be able to use their equipment with you in that power wheelchair. But I have had some people find some, but you might want to check with your dentist to see if you need antibiotics just in case prior to the visit. I know if you have like knee replacements or stuff like that, they always have you. Not a bad idea to ask. Make sure everybody, yourself and everybody around you, has all the vaccines that are out there. Make sure people wash their hands. And you know what? You have the right to say, out of here if you're sick. And you can also ask them to wear a mask. So traveling, I believe I'm a big fan of let's not stay at home. You can travel by car. You got your to-go bag. Make sure your ventilators are charged, your batteries. Ask if you can get an adapter for the car when you get to the destination. Remember, I said plug in, plug in. Traveling by air, a little bit harder to do, but not undoable. Talk to your airline. Let them know what they want, what you need. I know we're running a little over. I apologize. It was my mistake in the beginning, but if you need to get off due, I'm going to keep going. Have your, because we're almost done. Have your DME, have you asked them for a copy of the ventilator FAA approval in case they want to see it at the airport. Have a copy of your ventilator settings, the phone number of the company, any backup supplies, backup batteries. Go early and do not check any of this equipment. It can go through screeners. Okay. So now this is the last slide, and I'm going to be honest with you guys. It's probably the hardest slide. Wish it wasn't a slide. Wish it was a slide I didn't have to put in here. But to be honest with you, I honestly feel that if I don't share this with you, then this whole presentation is missing a valuable point. When we talk about going on a trach, you know, we're thinking about it like that, but we also need to think about what would make us decide, I don't want to do it anymore. I don't want to be on a trach anymore. I'm tired of doing this. I don't want to do it. How can you do that? I've had people say, well, how can you do that? Going on a trach is a medical treatment. We have the right to stop medical treatments. Okay. So boom, right there, you can do that. Not addressing this what we're going to talk about in a few seconds, not addressing it can lead to an unwanted quality of life. So you need to talk, you need to share feelings, you need to document in whatever, medical documents you have, whatever you have. So what am I talking about? What am I talking about? What are some reasons for going off of a ventilator? Why would you even think about it? Well, some people have, if you're a person that has recurring pneumonias and you're constantly in the hospital. I had a gentleman that was going to the hospital. Seems like he'd get out of the hospital only to get back in the hospital. For some reason, he was very susceptible to pneumonia. So that might be a reason. What if you're a person who over time increases in some form of dementia? Okay. And then the last one is one that I'm going to address, but I'm going to be honest with you and tell you really doesn't happen that often. It really doesn't. But I can't point at you and say, you don't have to worry about it. You have to worry about it. You don't. I can't. What am I talking about? I'm talking about what they call locked in syndrome. Right now with ALS, even if a person is unable to speak, they can communicate by using their eyes and the eye gaze computer. For the small percentage of folks that become locked in, they lose that ability to use their eyes. So they lose the ability to communicate, okay? They cannot do anything. I can only say at that point, you can't discuss it. You cannot discuss it. I wish, as I said before, we didn't have to discuss any of this, but I think it's something that you need to think about. So I'm going to take it to the next step that I've had people ask me. What happens if I want to stop using a ventilator? What happens if I decide to do that? Once you decide to do that, it is, as I said, form of medical treatment. It's usually done in a hospice situation, not necessarily in the hospital, not necessarily in a hospice facility, most of the time at home, in a comfortable setting, however you like, whatever music you want, with your family members that you want. You will be given comfort care and the ventilator will be disconnected. I'm going to jump back and explain comfort care. None of the medicines that they are giving you are accelerating the end result of passing away. They are not. They are truly comfort care. They're medicine for anxiety, and their medicine, and as crazy as it sounds, most of the time it's a morphine, but morphine helps with the shortness of breath. It will help with that feeling. So the person is not feeling like they're struggling for breath or suffocating. It's very peaceful. Okay. And usually after that, the person passes in a short amount of time. So I want you to know, I'm going to answer some questions that there are up there, but I want you to know that you can reach out to me at any time. I will be glad to, I'm going to answer these questions, but I will be glad to also talk to you on a one-on-one setting. So let's see what we got. Can you tell us what an emergent situation would look like? So an emergency, let's say that you, for some reason, you either don't have a piece of a mechanical equipment and you are starting to go into respiratory distress, or you have that equipment and you're not using it like you should. Usually it's a case where your CO2 has built up to where you can't breathe and you're in an emergency situation. So they're going to tell you, you know, in a lot of cases, they're going to say, well, this is what we got. This is what we got, which is why I tell people the biggest respiratory card we got, y'all, are these machines. Whether it's invasive or non-invasive, try to use it, try to get comfortable with it. Okay. I hope that answered that. Oops, where did it? As I learned to use the system here. As we plan for discharge to home, I am told it is more complicated than it used to be because the home companies no longer provide liquid oxygen for if supplemental demands. Can you explain how oxygen needs and vent interact? Woo, the word liquid oxygen. Hadn't heard that one in a long time. When I started home care, I love liquid oxygen. Too expensive, you're not going to find it. It's not done anymore. I would be hard pressed to find a company that did physical liquid oxygen. It's now all compressor machines, and for portability, it's all tanks. Okay. So you're not going to find liquid. Explain how O2 needs and vent needs interact. So the ventilator, all the ventilator does is providing the breath. You can actually attach the tubing if you need supplemental oxygen. I hope I'm answering the question you're asking. You just attach it to the back of the vent and it flows. The oxygen will come with the air of the ventilator. But you don't have to have oxygen to run a ventilator. The ventilator does it itself. But right now, most of the way that you're going to get oxygen at home is going to be in that concentrator, which is that big machine on wheels, or in tanks. I hope I answered that correctly. I heard of a percussion vest. Is that the same you described, that it is good to have in addition to a cough assist? Yes, a percussion vest. But you know what? Thank you. Thank you. Because you can also get percussion machines, like little handheld machines. They're not nearly as good, not nearly as good. But if it's all you got, it's all you got. The percussion machines, what they do is they provide wavelengths. So not only do they squeeze, they pulse. So it's sort of like this. Now, outside percussion, little handheld thing isn't going to do that. But yes, that's it. The brand name's Vest, but they have other manufacturers now. Oops, I've done that one. What is a breathing number? So a breathing number, when you go into clinics, they're going to do testing. They'll do a vital capacity or a forced vital capacity. That's that one that they take you to take a deep breath and blow, 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 blow. They're testing. That's what those numbers are. They're looking at those numbers. That's what that is. It's not how many breaths you take a minute at all. It's the numbers that you get off of these various tests that they do in clinic and in pulmonary function labs. Okay. What is bulbar onset? Good question. The bulbar onset, so ALS can be talked about in a couple different ways, but one of the ways we talk about it is where it started, how it started, what's your onset. Some people are limb, could simply start in your fingers, your hands, your legs, etc. Bulbar is it tends to start in, this is your bulbar region if you sort of draw down to your lungs. So these folks may have trouble breathing earlier. They may have trouble with speech. They may have trouble swallowing earlier. That it just so happens that it affects them there first as opposed to the limb. And what does O2 with only the trach collar? Does that mean O2 with only the trach collar should be less? Not sure if I understand that question, but what I'm going to tell you is when they are weaning a person, they will keep them, normally they keep them on oxygen because there's in an RT's vision, there's a reason you were on a trach. We got you on a trach with oxygen. We're going to wean you. We're going to wean you off of using the ventilator. We're going to slowly try to wean you off of oxygen. But the trach collar is they'll attach oxygen to it and humidity. And basically, it's just a provider of humidity and oxygen. Does that mean O2 with only the trach collar should be less? At that point, I don't really know how to answer that question. I mean, my mind's going in all different directions because they've got you on oxygen for some reason. Maybe in the beginning, you might need to be on oxygen. So they're not going to just totally stop the oxygen. My concern about weaning is more the actual being off of the ventilator for long periods of time. If that didn't answer it, give me a call or an email and I'll try to understand better. Okay. So I think that is it. Thank you guys for hanging in with me. And thank you for letting me start back over with the recording. And boy, I hope it recorded. So, all right, everybody. Thank you. Oh, there's one more question. Oh, thank you. Thank you very much. There's, you got this in front of you. Please don't hesitate to reach out to me. Thank you guys for coming. I'm not sure what next month's going to be. We're working on it, but I truly appreciate everybody that shows up. All right, y'all. Check you later. Talk to you later. Bye-bye. See if I can figure out how to stop share and end.